Hello everybody, happy Friday. Welcome to this week's HP Live webinar. I am not Michaela Connolly as usual. I'm Kelly House sitting in for her this week. And today we're happy to have Cultural Competency in Health Education, a Window of Opportunity. And before I introduce our presenters, just take care of a few housekeeping issues. This webinar is CEU eligible. As a live attendee, you get 25% off CEUs if you choose to do so, and there's a discount code in that chat box for you if you choose to do that. Also, speaking of the chat box, if you have any questions at any point during the webinar, don't forget them. Just type them into the chat box, and we'll have a Q&A session at the end, and your questions will get answered at that time. Let me see. I think that is everything you need to know. This is being recorded. It will be available on HP Live probably by Monday. And if you want to grab your own copy of the slides, those are out there on HP Live right now. So without any further ado, our presenters today. Today we have Dr. Raffy Luquis. He's an associate professor and the program coordinator of health education master degree in the School of Behavioral Science and Education at Penn State in Harrisburg. Dr. Luquis' primary teaching research interests include multicultural health, cultural competency and health promotion, community health, program evaluation, and human sexuality. Dr. Luquis has several refereed publications and more than 50 national, regional, and state presentations. Dr. Luquis is a fellow of the American Association for Health Education and the Research Consortium of the American Alliance for Health, Physical Education, Recreation, and Dance. He earned a Master's Certification Health Education Specialist credential from MCHECS in 2011. And we also have Dr. Miguel Perez. He has authored a book on health promotion, co-edited a book on cultural competency, and authored 9 book chapters as well as over 35 peer-reviewed papers in addition to sundry monographs and reports. Dr. Perez has served on numerous national, state, and local professional and community-based organizations, including service on the Board of Directors of the American Association for Health Education, appointee to the California Health Education Standards Advisory Panel, and CFO Secretary for the San Joaquin Valley Health Consortium. And we're really happy to have them both here today. So, Raffy, it's to you.
Good morning, or good afternoon, I guess, depending where you are. Thank you for taking the time to participate in this webinar. We hope to give you some sense of what cultural competency is and how we have an opportunity in health education to keep expanding this area of research. As you can see in the first slide, we have a copy of the cover page of our book that just came out. It's the second edition of the Cultural Competence in Health Education and Health Promotion. If you're not familiar with it, I will definitely encourage you to get a copy through Josie Bass and look through it. There's a lot of good information in there for practitioners as well as students in any health education program. Also, I just wanted to say a lot of information that we're presenting today is coming from that book, so that's basically a sense of it. A quick sense of the objective for today. We hope that by the end you'll be able to understand and explain what cultural and linguistic competence is. We also hope that you can discuss some way to integrate cultural and linguistic competence into health promotion and education. And finally, we hope that you discuss some strategies to promote cultural and linguistic competence in order to work effectively with different groups in the community as we serve them in this century. One thing I want to point out is that the way we're going to do this webinar today, I'm going to introduce the topic, I'm going to introduce some of the terminologies, and then I'm going to pass it up to Miguel, and he will continue talking about some of the issues and then give you discuss the strategies and so on. As Kelly said, if you have any questions, you can type them up, but we probably will wait to the end to discuss and answer any questions you might have. Now, one of the key elements, or one of the issues that we have to all address, is the fact that demographics have basically shifted in the last 10 to 20 years now. Census Bureau projected in the next 4 decades, and probably some of you are aware of this, we're going to be more diverse, and we're already becoming more diverse as we move forward. We have moved in the last few years. And the other thing is, you know, a lot of the population will move in urban areas, and you can see that if you look at a map of the United States, you have a lot of people concentrating in cities and surrounding areas. And the demographic shift as we move forward will still be controlled by immigration. One of the things that we'll look at, and we will discuss this in a couple of minutes, is that definitely Hispanic or Latino population, Asian population are still the two major groups of individuals that are immigrating to the United States, and that will continue. The other shift of the demographics, as some of you will know, is that we have the number of people who are 60 and older will continue to increase. In fact, many of the boomer generation are now under 60s. And that will bring a whole different set of needs for this group. Many of them is not the same as previous generation. Many of them are living longer. Many of them are still active. Many of them have different needs that maybe the previous generation of older population had. So we also have to be cognizant that what this population is getting older and what that's going to entail for health education. And as you can see by the graphic, 2012 all the way to 2060, how the numbers of all the population will continue to increase in millions. Another aspect of the demographic shift is the language of the population we are serving. As you can see by this particular graphics, in 2011, the top 10 languages spoken in the United States, they classify them as whether or not they can speak English very well all the way to not at all. And as you can see from top to bottom, German, French, Tonga, they still have one of the best skills when it comes to language speaking, English language speaking. But as you move down, Arabic, French Creole, Spanish, Russian, Chinese, Vietnamese, and so forth, you can see that some of these people, their skills are not very well. Some of them are well, and some of them are, the percentage of those who are not well increase as you move down, which this entails is that we also have to be more focused on, as we provide health education programs, how is language impact the information that we provide and communication of our program. How will language will determine what kind of information we're producing and how we're producing it. Are we producing an English-only material, or do we have to then translate it in all these different languages to make sure that the different population that we're targeting is able to follow the message? So that's something to keep in mind. So this is part of this cultural linguistic competency that we will be talking today. Last, when it comes to another graphic that we have here listed is, as this demographic shift continue, the non-white population are becoming more and more of the majority, quote unquote. If you look at the graphic 2012, the white alone population, this is the white alone non-Hispanic population, was around 78%. By 2060, they expect to be down to 69%. And when you look on the other side, Asian population will continue to increase. People who are two or more races will continue to increase. The other two groups pretty much stay the same. Black alone or African American will increase slightly. But the biggest increase I will still see it will be the Hispanic population. That will almost double, or more than double, in the next 40 to 50 years as we move forward. So you can see some of that. At the end of the graphic, just to explain this for some people might not understand it, is that when you take white population versus Hispanic population, so the non-Hispanic white alone, you see the big discrepancy, account for 63%, and it's go down to 43%. And that's the reason is based on the census. If you have seen it, they ask two different questions. Are you Hispanic origin, yes or no, and then are you one of the races? According to the census, the Hispanics are the only ethnic group, and therefore they have a separate question for that. Whether the other groups, white, black, Asian, Pacific Islanders, and so on, they're considered races, and therefore they have two separate questions. Many of the Hispanic, or the majority of Hispanic, consider themselves white, and that's how you see the big decrease or the change in the number when you see the white population in one side at 69% versus the other side say 43%. This is because it's accounting for that majority of Hispanic that considers themselves white race. Now, based on what I just explained or showed to you, basically this demographic shift then have established this need for cultural linguistic competence. We have to be able to understand and address the needs of this diverse population as we move forward. And now we have seen a shift in the last 10 years or so. As part of that, we have to know people's cultures. We need to talk about experiences, where they're coming from. Many of them are people who just recently migrated to the United States, and there are others who probably have been here second or third generation. So the experiences, whether they're here initially migrated in the last 5 years versus those who've been here second or third generation, is definitely a whole different experience, which will bring a lot of different type of influences in the cultures and how they behave when it comes to health and health issues. Language, as I mentioned earlier, also become an issue. Many of them are now becoming bilingual and bicultural at the same time. They're adopting the mainstream American culture, but they're also maintaining a lot of their culture. And many of them and the kids are able to speak two languages. So that's important to understand as we see. Yeah, the recent immigrants might only speak the original language until they get used to the United States culture and language. Age, as I mentioned earlier, that was one of the issues of older population. One of the things to emphasize too, not older overall, the older population is going to get the population will get older as we move forward. But we also will have a lot of the different racial ethnic groups who's going to get older at the same time, and they will bring maybe different sets of expectations or needs as the culture will influence their issues as they become senior citizens. And finally, we have gender and sexual orientation, which we cannot leave out of it, as we still see issues of gender roles, gender expectations among different cultures, and sexual orientation, as we have seen in the last few years, have become a whole separate group with specific needs and specific issues that we need to address when it comes to health and health education. So definitely, at the end, we go back to the same idea. We must become more culturally linguistically appropriate when it comes to health and health education and health promotion. The other thing that we need to emphasize is that, as you may saw, Healthy People 2010 and 2020 make the point that of the issue of diversity and how this is important. As you see by the quote, we're not created equal, therefore that will impact our health status. The other thing of that is and the term of health equity, which we won't have time to discuss much today, but that's a whole different term that people need to be aware of what it means and what it entails, is the idea that we must eliminate disparities and improve the health of all issues. In order to do so, cultural competency and linguistic competency play an important role in the aspect of decreasing or eliminating disparities. And here are some of the issues that affect health disparities, whether it's lack of information, lack of health insurance, belief attitudes, which individual belief attitudes will definitely go back to influenced by the cultural background, diverse healthcare providers. Recently, I was doing another presentation for a different group, and I look at the short of diverse healthcare providers. It's still, when it comes to healthcare providers, whether they're physicians, nurses, and some of the other healthcare allies, they still majority are white, part of the white population. If you look at the percentage, I think more and more of non-white population, African American, Asian, Hispanics, and so on, are going to those kind of fields, but yet their representation is still small compared to the numbers that they represent in the population. So that's something we also have to look at. And then we'll look at the issue of community that was definitely involved serious health problems and poverty. There's a lot of factors that go beyond this presentation, but that's something that also influence or is influenced by or is related to the issue of culture and background and so on. Now, this is just some definitions to make sure we're all kind of the same page. Diversity is basically including all of it: culture, belief, values, difference of all kinds. We also affirm the differences on ethnicity, race, gender, age, sexual orientation, socioeconomic status, linguistic, religious, political, special needs. I think it's important to identify that many times people talk about health education and diversity. Diversity is try to be really inclusive of all possible groups or all type of groups that are there based on all these different factors as presented here. Sometimes when we talk about cultural competency, we might just only concentrate or focus more on the culture of the individuals. But also we have to realize that there's a fine line between what diversity is and what cultural background is, and how all these two things almost go hand in hand and go together when we talk about these issues. Race, as I mentioned earlier, this is just based on skin color, hair color, shape, characteristics, and so on. And again, because one of the issues about race is that we have used race in the census and some other documentations. Race, it is meaningful, but at the same time is limited by the biology significance of it, because it's defined that way. So therefore, sometimes we talk about race, we might leave some groups out that are considered to be ethnic groups and not racial groups. And it's important that when we talk about diversity, we talk about race, cultural competency. We look at all these terms and get them understanding what they mean and what they refer to as we learn this process. Ethnicity, the next term on, this is more about cultural identity, learned behaviors, what human beings used to a natural social environment, demarcation within societies, and any group would share some common orientation toward the world, identify each of the others, pursue common genealogy and ancestry, and have some distinctive culture. So in a way, based on this definition, we can say, you know what, the way the census look at ethnicity and race, ethnicity go beyond just the Hispanic population. Ethnicity would include some of the countries from Asian, Pacific Islanders, would include even the African American or African countries. So there's important to understand that while we have this narrow defined census data that describe people as a race or ethnicity based on one specific definition, ethnicity might go beyond just that census data. So sometimes we have to then talk to the individual and say, well, how you consider yourself? Do you consider to be a racial group or ethnic group? What are your cultural identity? What kind of behavior you have? How you perceive you and you within a group of people, and how you see that as distinctive culture compared to somebody else. And finally, the concept of culture, which is more about what we learn, what we share and we transmit from generation to generation. How do we organize and interpret life, our style of communication, interactions, roles, relationships, practice, customs. Part of culture includes socioeconomic status, physical and mental ability, and we even add the issue of sexual orientation and occupation. And some people say, well, why is culture, what if physical and mental ability or sexual orientation and occupation part of a culture? Well, because they share specific belief system. They share specific value system that might be different those people who are not. For example, in the case of people who might be physical, have some limitations of physical ability, or have some mental difficulties of mental ability. They might have, as we look at culture, that's a different group of people. There's a different culture group that we need to consider. Same thing with sexual orientation. In the book, there's a whole chapter on sexual orientation, and the authors of that book make it clear that as a group, people who consider themselves part of the sexual orientation range, they consider to see themselves as a different culture group because they share different type of values and beliefs that might be against the mainstream America. So that's important. We understand diversity, culture, ethnicity, race, what all these terms entail as we talk about how to incorporate this into health education. This kind of a little summary of why do we need cultural competency and linguistic competence. Definitely, as mentioned earlier, demographic changes, disparity, how do we eliminate that, how do we improve quality of service. Many places, now many hospitals, healthcare facilities must meet legislative, regulatory, and accredited mandates, which mandate them to follow culturally linguistically standards, and we will talk about those later. If you are cultural linguistic competent, you might gain an edge on the marketplace. You might be more marketable as a health educator because you were able to work more, with a more diverse population. And at the end, for many healthcare practitioners, the idea that the more open they are to work with and able to work with different diversity and cultural groups and so on, they're able to diminish or decrease the likelihood of malpractice because they understand how to address the need of specific groups. This is the definition, some of you might be aware of this, the 2011 Joint Committee on Health Education and Promotion Terminology became two specific definitions that I wanted to share with you. Cultural competence, which we have used through the book as defined by this group, is the developmental process, values, principles, behaviors, attitudes, policies that enables us as health professionals to work effectively across racial and linguistic groups. It also entails at the organizational level there have to be a set of standards or a set of policies to coordinate and plan for those that they're serving as an organizational level. Culture of confidence have been a new term that been added in the last few years. As we talk about cultural competency, we talk about a long life journey that we go through, so that's what we define cultural confidence, that lifelong process, how you go through self-reflection and understand your own biases and your own prejudice in order to understand the complexity of the issue that's surrounding this topic. As part of this cultural competence, as you mentioned, it's a cultural journey. It's awareness of accepting the difference. It also includes acceptance of your own cultural values, which might not be the same as other people. Include that commitment to honor and respect the belief and values of other people. It doesn't mean that you have to agree with everything. It just means that we are honoring and respecting that as we move forward, and then we try to learn from them as we become more culturally competent. And include that ability to develop and adapt and implement practices that fit the cultural context. Once again, it's dynamic, it's always changing. As people change, as you change as an individual or the profession, you meet more people, as your exposure to different diversity and different cultures, your own cultural views, your own cultural values might change. Therefore, this process is really dynamic and ongoing. Some of you probably have seen the cultural competence continuum that basically goes from destructiveness to cultural proficiency. And in the past, we have made the point to make sure that people understand that, the destructiveness is that individual that's still out there. Many people still promote this superiority concepts versus other groups being inferiors. And we know now that that's a negative way to approach things. And yet we still see this today in the news, or we see this sometimes in cases in real life that you'll be working with. But then we hopefully people moving to the other way, which, still people who might feel indifferent might be the people who, they say, well, people is out there, but I don't care much about it. Hopefully move to more of awareness, understand their differences, and a little more susceptible to understand those, with competence to become more effectively, and hopefully proficiency, which is basically the highest capacity. Understanding that sometimes we might not be able to be completely proficient because, again, culture change, people change, things are changing, but that's what we are moving towards. So basically, this is the journey of cultural competency. The idea that, again, you have to say your own culture, you have to value diversity, you have to manage the dynamics of the difference by appreciating this power conflict, understanding that some cultural groups still believe they're superior than others, or they feel that they're better off than others because, history or belief systems or so on, and we have to understand and manage those dynamics to make sure that we are being fair to all the population we serve, and then so resolving the conflict that this might arise because of those dynamics, adapting to the diversity, and continue learning as we move forward because, again, this is a learning process, not just an end to it. And finally, in the institution that we work, we need to institutionalize this cultural knowledge, cultural competency, and cultural awareness, and linguistic competency, because that's part of who we are as a group. And if we don't do it, if the institution refuses to do it, then it's not much we can do as individual. There have to be a process that have to be in collaboration institutionally as well as individual that we serve in our community. Here's the end of my part of it. I will pass it now to Miguel, who will elaborate on some of the other concepts.
All right, if we can go to the next slide, Raffy, appreciate it. You know, one of the things that Raffy showed us a few minutes ago is not only the change in demographics of the U.S. in how we have a kaleidoscope of individuals from many different countries, but as he also alluded to, the fact that individuals are coming from a variety of countries from throughout the world also imposes the need to be able to communicate with those individuals and be able to deliver quality health education and prevention programs that will enable them to live a healthier and happier life. So, you know, a few years ago, the concept of cultural and linguistic competence were brought together because we realized, experts in the field realized that you cannot have one without the other. So while Raffy focused on the concept of cultural competence, I'm going to talk a little bit about linguistic competence and then bring both concepts together, again, understanding that some of you may have far more knowledge and experience in this regard, but I wanted to start my section by talking about, you know, what is actual linguistic competence. And, you know, in the simplest terms is the ability to effectively communicate with people. And we think that we do that easily. You know, we speak a common language. But just because we speak the same language, that does not necessarily mean that we use the same terminology in the same context. So it is important as you're planning health education programs and looking at those all-important needs assessments that I know that every good health educator does at the beginning of the programs, that they understand the audiences, not only in terms of the diversity that it may be visible through race and ethnicity, but also through their ability to communicate in both in written and language form, and also in terms of the body language that conveys information. So in order to be linguistically competent, and I wish I could tell you that you're going to be that after speaking, after listening to me ramble on, I won't lie to you, that's not going to be the case. This is a foundation, what we're trying to give you. Because the reality is, in order to achieve linguistic competence, you need to employ a myriad of strategies to be able to communicate. And what works with one audience may not work with another. You know, we as professionals are utilizing this wonderful technology, and you know, the organizer and the panelists are 3 different states, and many of you are scattered throughout the United States. But that's not something that is available to everyone. So how do we actually reach out to them? And I wanted to share with you 3 resources that can actually help you as you move through this journey. One of them, and many of you, if not all of you, are probably familiar with the National Center for Cultural Competence. If you are not, I would strongly encourage you to spend some time going through their website and finding all the resources that they have compiled, and they're free and available to the public. They should be able to make your life a little bit easier. The Agency for Health Research and Quality has an initiative called the Innovations Exchange that may also be of use to you as you move through the journey of devising and providing linguistic competence. And last but not least, the Center for Cultural and Linguistic Competence in Healthcare. And why healthcare? Because unfortunately we don't have standards for our own profession in health education yet. We're working on them, but we're not there yet. So then the Center for Cultural and Linguistic Competence in Healthcare, it would be a 3rd resource that would be important. So how is this concept of linguistic competence been applied. And what does the research tells us? Well, the research tells us that language, spoken words are important, but sometimes the technologies or the tools that we use are not adequate to communicate with our patients or with the people that come to our seminars. So, Rafi, if you can go to the next slide, I'd like to share with you a tool that has been developed to look at, many of us are used to going to the doctor, and the doctor asks, I'm in pain, and they say, so on a scale of 1 to 10, tell us, how much does it hurt? And we pick a random number and we say, this is how much it hurts, and they know. But the research tells us that approach does not work with patients who may have limited English capabilities. So some of the standards that have been developed in linguistic competence include the development of the Universal Pain Assessment Tool. And the reason I am sharing this particular tool with you is because it can be adapted to be utilized in, Rafi, if we can go to the next slide, please. If we could, it can be used in order to address different groups. And you can take the examples that are used through the universal pain scales and modify your instruments when you're doing those needs assessments to, instead of using words, instead of using what we're used to, the multiple choice or open-ended responses, perhaps the incorporation of more pictures that will enable you to be able to communicate effectively with the populations that you seek to serve. So when we're thinking about linguistic competence, we're thinking about having a staff that are both bilingual, bicultural, and they're also multilingual. All right, so that helps because it facilitates the communication. But one of the mistakes we often make is that we think that because we have a Hispanic person, I am using Hispanics because I am one, or because we have a person who speaks Spanish in our organizations, that person all of a sudden is an expert in every group that comprises Hispanic populations. And that is a sad mistake because it doesn't always happen that way, and we'll talk a little bit more about that in a few minutes. But how are we able to communicate? Many of us know about nonverbal communication, looking at the eyes or not. So those are issues that you need to be looking at if you're trying to communicate with people. For individuals, foreign language interpretation services. And notice that the term that we use here is interpretation, not translation. And there's a very reason for that, in terms that interpretation is bidirectional. So it allows people to communicate simultaneously, going back and forth. When you're using translation, it's usually one direction. So you're translating from say from English to Japanese and back from Korean to English, but it's one directional. Interpreters are actually active in the process, and if you don't have that ability, even though you may be proficient in the language, having the ability to interpret simultaneously is a skill that is difficult to obtain and that is highly valued. So if you have a staff like that, or you are one, it's great, but it takes time to actually develop those competencies, if you would. Another way that you can be a linguistic competence is to have materials that are easy to read, that are designed for low literacy populations, and they have pictures and symbols. Again, many of us in our work rely on materials that are developed by other organizations. And the reality is most of them are very good and they have accurate information. But we've got to be careful that the language, the terminology, and the reading level that is used is actually accurate. And this was driven home for me a few years ago as we did some research with a graduate student looking at the reading levels for materials that have been developed to educate patients with diabetes. Uh, and even we tested a number of materials that were developed at the national, state, and local levels, and we discovered the majority of them were far higher. The reading level was far higher than the populations that they were trying to reach. So that's something to keep in mind, is as you develop materials, testing them, and there are some tools that enable you to determine those reading levels. Again, another step being linguistically competent in reaching those populations that we want to reach. Having materials in alternative format, which is either audio tapes. Many of us like to listen to audio tapes on our cars, or if you're visually impaired, it may be the only way that you can actually get them. Braille, if we're working with an elderly population, as Raffy showed us earlier, the population, we're getting older as a nation. Having a large print might make it easier for those populations. So those are kind of important things to keep in mind. And again, if you decide and develop and implement a needs assessment, these are things that you would capture at the very beginning and be able to develop and implement and evaluate your health education and promotion programs and make sure that they're both culturally and linguistically appropriate. You may not be in an area where you have the luxury of having a staff who are bilingual. There are translation services out there that you can hire. Some of them you may be able to actually access on demand, and you do that through sometimes just calling an 800 number. But again, it goes back to being able to communicate with the population and using an interpreter rather than a translator. Raffy, if we can go to the next slide, please. Okay. No, I'm sorry. Next slide, please. All right, little technical glitch there, I'm sorry. The idea of cultural linguistic competence health education is not new. The now defunct American Association for Health Education actually released the first standards, the first guidelines for health educators back in 1994, and again reaffirmed that position in 2006 when they released a position statement on cultural competence that I believe my distinguished colleague was the chair of the committee that actually developed that document. In 2002 and 2005, Sophie provided leadership in passing some resolutions that were designed to eliminate racial and ethnic health disparities. That incorporates the need to be culturally and linguistically appropriate. But as I indicated earlier, we still, even though we started this process in 1994 with those guidelines for health educators, here we are in 2014, and we still don't have discipline-specific standards, which is not necessarily bad, but it does provide a reason, an area of research, and an area for us to collaborate and develop those standards that are going to be very applicable to the type of work that we work in health education. Next slide, please, Raffy. Some of you may have heard about a new law that fully came into effect in January this year, the Patient Protection and Affordable Care Act, ACA, also known as Obamacare. And one of the things is this particular law actually makes it a requirement to collect data about the demographics of the populations that you serve. And once you have that information, it also expects you to do something with that information so that the services that are provided are good. So in that case, from that perspective, the Affordable Care Act actually put some teeth behind the class standards that, as we're probably all familiar with, but if we're not, I'll just introduce them briefly to you in a minute or two. But again, the idea is that regardless of where we are, we're providing cultural, linguistic, appropriate services to the populations that we have. You may or may not be familiar with this, but in 2010, President Obama signed into law the Plain Written Act, which mandates all federal agencies to avoid jargon and to communicate in plain and simple language. And two executive orders, 12866 and 12988, have actually put that law, the Plain Written Act, and codified into regulations, and is being implemented throughout the federal government. Usually, if the federal government is doing it, organizations that receive federal funding will be required to follow suit pretty soon. So you may already be doing this in your agencies, but if not, this will be coming down the pipeline. It's being able to communicate with people in plain and language. If we can go to the next slide, Raffy, please. I had mentioned a couple of minutes ago the standards for cultural and linguistic appropriate services. These standards have been around for quite a while. There is a URL that you can access the entire document, and they were re-released last year, and very important. But I wanted to call your attention to what is now called the principal standard, or standard 1. And that standard actually calls for providing effective and understandable and respectable quality care for the populations that we work. And even though the class standards are focused on health care, I believe that there is a lot of those standards that apply to those of us who work in health education and in health promotion as we attempt to deliver quality services to the populations that we reach. Next slide, please, Raffy. So many of us in health education have been trained to utilize a variety of models, planning models, and I don't have to recite them for you. You probably do a much better job than I could in that area. But again, I just wanted to point out that those widely used models still are missing a cultural linguistic component. So it is incumbent upon us as health educators to remember that and to understand that as we develop those needs assessments, as we are going through those planning processes, as we're developing the educational materials that we're going to share with our populations and our target groups, that we've got to keep in mind and incorporate that cultural and linguistic competence, because not only is it good practice, but it's also requirements that we need to follow in our day-to-day activities. Raffy, can get you to go to the next slide, please. Thank you. So as I was saying, it is important to actually incorporate this. Needs assessment, it's one of the first things that we need to do as health educators. And those assessments will give us a great source of information, not only to where the health knowledge and behavioral deficiencies are, but also they should tell us who our populations are, what their educational levels are, what their backgrounds are, what their reading levels are. And if you actually do it right and invest the time, it should also give you information about their preferred learning styles, so that as you're developing your interventions and your education programs, you're actually able to reach the population and have them actually use the information that you develop to live healthier lives. Raffy, if you can go to the next one, please. We talk about, culturally appropriate evaluation is, again, knowing who our populations are, being able to collaborate with representatives from the target population, and, again, being able to collect information from different places. One thing I mentioned before is don't ever assume that because you have a person from a specific racial or ethnic group, that person is all of a sudden the expert in the subject matter. Raffy and I were lucky to publish a paper, I think it was last year, correct me if I'm wrong, Raffy, on getting to know U.S. Latinos. And it was published in the California Journal of Health Promotion. And what it is a game. It's a Jeopardy type of game where you can actually explore different facets of the Hispanic culture as well as the cultural practices and the health practices. And even though I've been doing this for a while, I gotta tell you that writing this paper was one of much of a learning experience for me. And so again, don't ever assume that a person from a specific ethnic group is going to be representative of knowledgeable about everybody in that particular race or ethnic groups. Next slide, please. Thank you much. Again, as we're taking a look at one of the things that we look at our needs assessment, it should give us information on the education. Education in the U.S. is very formalized. We do have the ability to, based on your skills, to achieve as high of education as you can, and there are many different programs that are put together to facilitate that process, but we need to be cognizant that that is not true throughout the world. And so as we interact with populations who may have immigrated to the U.S., they may not be very accustomed through our educational system. And in the U.S., our educational system teaches us and gets us used to multiple choice tests and true and false tests. And so when we're developing intervention and we're doing our evaluation tools, you know, we follow those patterns because that's what we are used to. Again, your needs assessment should tell you whether or not your population, your target population, is going to respond well to those particular methodologies. And the education, just because a person is educated does not mean that they are health literate. That's another component, and well, it's beyond the scope of what we're trying to do today. Understanding that just because a person can read and write at a certain reading level does not mean that they're going to be able to assimilate health information that you provide to them. Can we go to the next slide, please, Raffy? You know, again, so, you know, you use language to be able to communicate, right? So being able to speak in a person's native tongue is very useful, but that don't assume that it's always going to work. You're going to have variations in preference on language, people who prefer one language over another, people who prefer one language to discuss some topics and a different language to speak about something else. And usually people will revert to their native tongue when they're talking about health, their health and their needs, their wants, and their fears. So make sure that your programs are actually, in this case, I use the word translation in the slide, assuming that we're talking about written materials. And again, remember that one direction, you have developed something, you're providing it to your target audience. So, you know, in that case, it should still be respectful. If you're having a conversation, that will be more of an interpretation. Again, something else that sometimes we forget, it seems so simple, that we are so used to in the U.S. providing materials to people to walk away and read and digest. Our moderator, Kelly, told you at the beginning, you know, you can access the slide through the website and you can download them, and some of you may do that. But sometimes when we're working with low literacy populations or we're working with immigrant populations, they may not have reading abilities, and so developing written materials that have a lot of words and very little graphics is not going to be very effective. So another thing is, as you're doing this, your health education programs, is what we're calling the cultural protocols. Knowing that there are going to be some culturally sanctioned behaviors that are acceptable to a population. Doesn't mean that they're good or bad, it's just the way it is, and you have to work with them. And unfortunately, you're not going to change them in a one-time approach. So just being able to understand that. So, you know, you're having a weight reduction program among, say, a first-generation Hispanic population. Your ability to be effective may be hindered by the fact that in some Latin American countries, being overweight is still seen, even in this day, as a sign of wealth and prosperity. So now you're asking the person to get rid of something that physically and outwardly expresses that they have arrived and they have made it. So how do you take those cultural protocols and use them to your advantage to make sure that people do what they're supposed to do and live a healthy life? Raffy, if I may ask you to go to the next slide, please. So what are some of the things that you can do in order to reach populations? One of them is you must develop trust and be sensitive to what are considered pillars or those cultural protocols in working with different cultural and ethnic groups. Being willing and being aware that regardless of who we are, regardless of our educational level, regardless of our race and ethnicity, cultural competence is a journey it's a journey that we employ and that we live. So being willing to learn and look for best practices in materials that have been designed is a great thing. You can develop sensitivity and trust and credibility as you work with populations. We're not asking you to accept what people believe to be true in their communities, but we do ask you to be respectful of those and to have those cultural protocols in mind as you are developing your intervention programs. And last but not least, having a collaborative partnerships with people from the community. So it's very time consuming and it's very expensive too, but having representatives from the communities review the materials that you develop for your interventions is very useful. Next slide, please. So some additional strategies for health educators. You wouldn't be here, I don't think, if you did not recognize the importance of culture and respecting diversity. But one of the things that you may not be doing now where you are, and is one of those requirements by the ACA, is to maintain a profile, the cultural composition of your communities. Is going to make your life easier as you develop your health education and prevention programs. Language preferences, generally speaking, again, the older the generation, the more set they are in their styles. Younger generations tend to prefer more contemporary forms of communication, technology, and what have you. The idea of cultural brokers is something that has been tried in the last decade, and it seems to be working. But again, you have to, this is one of those things, caveat emptor, let the buyer beware, where you need to understand how these cultural brokers have been trained, what their background is, where they're coming from. And last but not least is, take the time to assess and evaluate your programs, your organizations that were cultural linguistic competence. And this is an ongoing process. It's an ongoing process for all of us, but the more we do it on a regular basis, the better off we are, and it helps us on that journey to being able to reach the populations that we want. It helps us do the things that we want to do. So, the bottom line is, and thank you for getting there, Raffy, is that what we want to have is a trained workforce that continues to have professional preparation programs to continue in education, to interacting with their colleagues through readings and through attending this type of seminars. Next slide, please. So what are the things that we really want you to walk away with, and then I'll turn over the floor to the audience for any questions they may have. So, it is important for us to be mindful of health education, for culture and in linguistic issues. Even though they are not part of the planning models that we may have learned, we need to be able to incorporate those into our needs assessments. It is our job as health educators to promote that cultural linguistic competence so that we are able to work with individuals. And even learning one or two, three key phrases in the language of the population that you're going to do just will help go a long way into establishing that rapport and the trust that you need in order to reach them. The downside to that is that you begin throwing little words out here and there, and people may erroneously believe that you're proficient in the language, and that can create a different problem. But I'd rather have that one than not be able to connect with my target community. You probably have a wide arsenal for good strategies for reaching populations, and it's important to share those. If you got some ideas that you want to share with us today, it's fantastic. If you're in a position and willing to publish to the professional literature, it's fantastic. If you want to share those through target publications in the communities that you work in, it's great. The idea is for us to share the information. And as health educators, you know, one of the entry-level competencies is to be a resource program, resource person rather. So being able to share what we have is really good. And so again, it's a bias of ours that we don't have cultural linguistic standards for the populations that we serve, and we think the time is now. So thank you so much for your attention, for staying with us through this time. Any questions that you may have?
Thank you so much. A lot of really great information. So I'm going to remind everyone again, because it usually takes everyone a minute to get going, but please type any questions or comments that you may have into that chat box, and we will get them answered for you here in the next 5 minutes. And I also suggest any suggestions that you have found, like Miguel had just mentioned, to reach different target populations, share those as well. Make it kind of an interactive experience where we can all help each other out. Okay, especially the example you were giving about giving the reading materials and sending them home to somebody who's not going to be able to read them. I don't know if you have any suggestions on how do you reach somebody like that? Oh.
Raffy, you want to take that one, or you want to do it?
Well, I think when it comes to reading materials, many years ago, I was approached by no other than the American Cancer Society, and they said, you know, we have all this material we give out to people, and they don't seem to read it. And I basically said, well, have you ever asked them if they understand it and you know, what it means, or whether they can picture themselves in the information you give? And they give me their brochures, and there was basically written in English, you know, for a mainstream population. And in this case, it was the Hispanic population. I said, well, maybe we should give it to a group of Hispanic women and let them read it and tell us what they think. And that was a way to get information back to the American Society and said, you know, here's what they feel. They don't feel that they're represented in this material. They don't feel like they relate to them in any other way. So maybe you need to develop material that is more, have pictures that represent an Hispanic woman, have some of the language that they might be familiar with, understand where they're coming from. So that was a process that we went through. And I think whether or not, you know, it was better out, I think at the end was the idea that you develop material that people would then read. Otherwise, you're just wasting your time.
Yeah, and Jamie just wanted to know if the slides or the webinar will be available on the website. The slides are available now on hplive.org, and the video will be processed and available early next week at the same place. So, and I know when I speak Spanish horribly, probably really bad. When I am speaking with someone from a different culture or who not a native English speaker, I think how would I want them to tell me in Spanish so that I would get it? and kind of use those words, you know, if I was listening to this in Spanish, what level do I need it to be at? You know, pretty low.
Yeah.
And kind of consider that as I'm talking to somebody else.
Actually, that's a good standard that you're using. You know, how would it be if I were actually on the other side? So thank you.
Okay, we're not getting a lot of questions. We are getting a lot of great jobs and a lot of thank yous. So it's good to know everyone appreciated our webinar today.
I just want to mention quickly that when it comes to language, Miguel and I both speak Spanish, and you know, I was born in Puerto Rico. Miguel was born in Los Angeles with a Central American background, and even with his wife, which is from Colombia, you know, it's interesting that sometimes when we get together, we'd rather speak in English because it's just easier that way than try to speak Spanish. We might have a whole variation of verb and words that we use for the same concepts and so on. So I think we need to understand that even though in the Hispanic community people speak Spanish, there's so much variety of it, and there's so much linguistic diversity within the Hispanic community. So sometimes you have to be careful what word do you use in a different language, because whether you're dealing with a Mexican population or Puerto Rican population or Cuban or Central America, it will vary a little bit. So I think that's part of the linguistic competency, understanding that one language approach might not be it might be the easy answer, but at the same time we need to move from there and say, well, okay, what else do I need to consider when you talk to different people who might speak what I might consider the same language, even though it's a variation of it.
Right, and most of us that speak English have watched a British television show and not had any idea what they were saying. So
It's not true. That's very true.
all right, well, getting a lot more thank yous, and our time is up. If you do think of a question, go ahead and you can forward it to me, Kelly, at hpcareer.net, and I'll forward it on to our speakers today. And otherwise, thank you, everyone, for coming, and have a great rest of your day.
Thank you.
Thank you very much.
Bye-bye now.
Bye-bye.
Bye.